Hi everybody, and welcome to our module on coagulation. Thrombus formation is the way that the body prevents blood loss when there's damage to a blood vessel. So when the endothelial lining to any blood vessel is damaged, two processes are initiated that lead to formation of a thrombus. First of all, platelets become activated, and I talk about how this occurs in another module. And then in this module, we'll focus on coagulation, which leads to formation of an insoluble substance called fibrin, which forms a clot to stop blood loss. Before we talk about coagulation, I want to mention that vasoconstriction is the body's first line of defense against bleeding. This occurs before any thrombus is formed, and it occurs in response to endothelial damage. The important mediators of this effect are substances called endothelins. These are proteins that are very potent vasoconstrictors. They are released by endothelial cells near sites of damage. And if you've watched the module on pulmonary hypertension, you know that there are drugs used in pulmonary hypertension which are endothelin receptor blockers. And this should make sense to you if you appreciate that endothelins cause vasoconstriction. So back to our discussion of thrombus formation, we're going to focus on how fibrin is formed by the body. And in order to understand this, we need to understand the coagulation factors. Coagulation factors are proteins that are synthesized in the liver. They are soluble in plasma and they circulate in the blood, and they become active when they are triggered by endothelial damage. They work together to form an insoluble protein called fibrin, which will form a mesh to prevent blood loss at sites of endothelial damage. The coagulation factors are named by Roman numerals. For example, there is factor 1, factor 5, and factor 10. They all circulate as inactive enzymes, which are called zymogens, and when they become activated, an A is added to their name. For example, 1A or 5A or 10A are the activated forms of clotting factors 1, 5, and 10. And you should know that many of them activate to become a special type of enzyme called a serine protease. So serine is an amino acid. This is its structure shown on the screen. A protease is an enzyme that cleaves proteins, so serine proteases are protein cleavage enzymes that contain the amino acid serine, and many of the coagulation factors activate to become serine proteases. The coagulation cascade involves the sequential activation of the clotting factor zymogens. For example, 12 will become 12A, and then that will activate 11 to become 11A, and there's a constant low level of activation of these clotting factors occurring all the time in your plasma. However, the process will amplify when there is endothelial damage, and this will lead to the generation of fibrin, which, as I told you before, is that insoluble protein that can precipitate out of the plasma and form a thrombus. This slide is an illustration of the coagulation cascade like you can find in a textbook of hematology. You can see that it shows how the clotting factors are activated sequentially, ultimately leading to the formation of fibrin, which forms a cross-linked fibrin clot. Now, the problem with pictures like the one shown on this slide are that they're very confusing and they're very hard for medical students to remember. So in the next few slides, I'm going to give you my system for keeping this straight and understanding the most important points. One of the most important things to appreciate about the coagulation cascade is that the center of the cascade involves activation of factor 10 to become factor 10A. Factor 10A is an enzyme which can convert prothrombin into thrombin. Prothrombin is also called factor 2. Thrombin is then an enzyme which can convert fibrinogen into fibrin, and fibrinogen is sometimes called factor 1. And as I told you before, fibrin is insoluble and it will precipitate out of the plasma and form a plug to stop bleeding. So the key point is that once you activate factor 10 to become 10A, this will lead to the formation of fibrin, and that is the center of the coagulation cascade. So as I've shown on this slide here, once factor 10 becomes activated as 10A, that will necessarily lead to the formation of fibrin, which is the key component of forming a thrombus. And this is the basis for a lot of pharmacology. There are drugs that are factor 10A inhibitors, drugs like rivaroxaban and apixaban. They inhibit the factor 10A enzyme and decrease the formation of thrombin so that blood clots don't form. There are also drugs that are direct thrombin inhibitors like the ones I've listed on the screen here. They inhibit the enzyme thrombin and decrease the formation of fibrin. I'll talk about all these drugs in more detail in the module on anticoagulation therapy. So now that you appreciate that activation of factor 10 leads to formation of fibrin, we need to understand what activates factor 10 in the setting of endothelial damage. And to understand that, we need to talk about tissue factor. Tissue factor is also sometimes called thromboplastin. It is a glycoprotein that is constitutively expressed in subendothelial cells. Importantly, however, it is not expressed by endothelial cells. This means that when the endothelium is intact, there is no significant contact of tissue factor with circulating blood. However, when there is endothelial damage, tissue factor becomes exposed, and this is the major activator of the coagulation system and the coagulation cascade. So the primary event when there is endothelial damage is exposure of tissue factor. Tissue factor will interact with factor 7 in the blood and convert it to factor 7A, and the tissue factor 7A complex will activate factor 10A. And remember what I told you before, once you activate factor 10A, that is going to lead to the formation of fibrin. So we can now add to our diagram of the coagulation cascade and show that when endothelial damage occurs, this exposes tissue factor, which can activate factor 7A, and together they can convert factor 10 to 10A, and that will lead to the formation of fibrin. Now this could be the entire coagulation cascade depicted on the screen here, and it probably was a long time ago in evolution. However, it's not very efficient, so our bodies have evolved ways to amplify this system so that more fibrin can be formed. And the way that our body amplifies this system is by using thrombin as an activator of numerous other coagulation factors. It's very important for you to understand that thrombin can make more thrombin. In other words, even though thrombin is created by the coagulation cascade, thrombin may also activate the cascade via positive feedback. The way that thrombin does this is by activating a number of other clotting factors which amplify the clotting cascade. So for example, thrombin can convert factor 5 to 5A, factor 11 to 11A, and factor 8 to 8A. Factor 11A, which is created by thrombin, can then go and activate factor 9 to 9A, and factor 9A can activate 10A and therefore amplify the clotting cascade. So the bottom line here is that all of these factors, factor 5, 11, 8, and 9, what they all do is become activated in one way or another by thrombin and then amplify the clotting cascade so that thrombin exerts positive feedback. The details of how each of these factors work are complicated. You can read about them if you wish. They all carry out their role in a little bit of a different way. For example, factor 5A is a cofactor for 10A. That's how it supports 10A activity and increases the amount of thrombin. Factor 8A binds to factor 9A, and the two of them together can create more 10A. So basically all of these factors work in a little bit of a different manner, but the net effect of all of them is to increase the activity of 10A and therefore to make more thrombin. So now I've added these other factors into our diagram of the coagulation cascade so you can see that what thrombin can do is activate these factors, and they all go to support the activity of 10A and increase the amount of 10A activity, which therefore ramps up the clotting cascade and makes more thrombin. And there's a clinical tie-in here because, as you may know, children born with hemophilia lack either factor 8 or factor 9. And now that you understand the role of these factors, you can understand that children with hemophilia cannot amplify the clotting cascade, and therefore they are vulnerable to bleeding. Let's talk in a little more detail about factor 8, which is one of the clotting factors used to amplify the coagulation cascade. Factor 8 is unique because it's produced in endothelial cells, not in the liver like most of the other clotting factors. Another unique feature is that factor 8 circulates bound to von Willebrand factor. Von Willebrand factor is critical for platelet aggregation. I talk about it in more detail in the module on platelets. For our purposes here, I'll just remind you that von Willebrand factor is also produced by endothelial cells, much like factor 8. In addition, it's produced by megakaryocytes, and for that reason, you can find von Willebrand factor stored inside of platelets. By binding to von Willebrand factor, the plasma half-life of factor 8 is greatly increased, and that's why you can find factor 8 bound to von Willebrand factor in the circulation. When there's vascular injury, factor 8 is released from von Willebrand factor, and thrombin activates it to become factor 8A, as we talked about previously. Some of the coagulation factors do not work in isolation, but instead they function as part of a multi-component complex. There are two complexes that form from multiple different coagulation factors, and they both work to convert factor 10 into 10A. Both of the complexes include three components bound together. One component is an active clotting factor which works as the enzyme, another component is a cofactor, and the last component is the substrate, which is always factor 10, which will be converted to 10A by one of these complexes. Both of the two complexes require phospholipids and calcium to function. The fact that they require a phospholipid means that their reactions will occur on the surfaces of cells. So these two complexes work either on the surfaces of tissue factor-bearing cells or on platelets, and they both require calcium because calcium is a cofactor for both of these complexes. So the first complex is called extrinsic 10-ACE. It converts factor 10 into factor 10A. It consists of a phospholipid that comes from tissue factor-bearing cells. The enzyme is factor 7A, the cofactor is tissue factor, and the substrate is factor X. The second multi-component complex is called the intrinsic 10-ACE. It functions on top of platelets. That's where the phospholipid comes from. The enzyme for this complex is factor 9A. The cofactor is factor 8 or factor 8A, And the substrate is factor 10. Remember, all these complexes convert 10 to 10A. If we go back to our diagram of the coagulation cascade, these are the two multi-component complexes. One includes tissue factor and factor 7A. It will convert 10 to 10A. The other one involves factor 9A and factor 8A. It will also convert 10 to 10A. Both of these two work as a package of an enzyme and a cofactor, along with phospholipids and calcium. That's a nice segue into a discussion of calcium. Calcium used to be called factor 4 because it is required for clot formation just like the other coagulation factors. Platelets store calcium, and when they are activated, they can release calcium. And when you draw a blood sample, many times you will store it in tubes like this that contain EDTA. The reason the tubes contain EDTA is because it will bind calcium, and this will prevent the blood from clotting while you transport it to the lab. Now let's talk about factor 13, which we haven't discussed yet. The job of this coagulation factor is to cross-link fibrin once fibrin has been formed. By doing so, it stabilizes the fibrin plug. So if there is an absence of factor 13 for any reason, fibrin will form, but it will be inadequate because it is not cross-linked. Factor 13 requires calcium as a cofactor, and it's activated by thrombin just like fibrinogen. So back to our diagram, we can now add in factor 13, which functions right here along with calcium to cross-link fibrin. It is activated by thrombin just like fibrinogen. The last coagulation factor we have to discuss is factor 12. It's also called the Hagman factor, and factor 12 can activate factor 11 to become 11A, just like I've showed you at the bottom of the screen. Now I told you before that thrombin can convert 11 into 11A, but factor 12 can do this as well. The physiologic significance of factor 12 is unclear. There are patients who lack factor 12 and they coagulate normally. The greatest importance of factor 12 is for testing the coagulation system. This is because factor 12 is activated by contact with negatively charged substances like silica. So if you expose factor 12 to silica, it will become factor 12A and it will activate the coagulation system. And this is the basis for the blood test called the partial thromboplastin time, or the PTT. So this is the way I like to think of the coagulation cascade, because it helps to remind me that inside the body endothelial damage initiates the cascade, and then these factors over here amplify the cascade. This is the way, however, you will often find it written in textbooks, and the reason it's written this way is because it shows that there are two ways to form fibrin. The first way is called the tissue factor pathway, where tissue factor leads to this cascade of changes, and that leads to the synthesis of fibrin. The other way to activate the cascade is by starting with factor 12. That will lead through this cascade of changes, which also leads to the formation of fibrin. And when it's written this way, there's usually a little notation like the T I've shown here to indicate which factors are activated by thrombin. The reason textbooks like to write it this way is because this is important in the laboratory for testing the coagulation cascade. The pathway that begins by factor 12 is called the intrinsic pathway, and the pathway that begins with tissue factor is called the extrinsic pathway, and they are tested separately inside the laboratory. The test for the intrinsic pathway is called the activated partial thromboplastin time, or the PTT. To do this test in the laboratory, you take a sample of a patient's plasma and you add it to a negatively charged substance, usually silica. And as I told you before, negatively charged substances will activate factor 12 to 12A, and that will lead to the formation of fibrin. And you measure the time it takes to form a clot, and that time is the PTT. The test of the extrinsic pathway is called the prothrombin time. In this test, tissue factor is added to a sample of a patient's plasma. That will initiate the cascade in this manner and form fibrin, and you measure the time it takes to form a clot, and that time is called the prothrombin time, or the PT. Let me add a few more details about the intrinsic pathway. This is the pathway activated by factor 12. It's also sometimes called the contact pathway because it's activated when plasma comes in contact with negatively charged substances. The intrinsic pathway requires kinins for normal function. Kinins are peptide hormones or signaling molecules. They have short half-lives, so they circulate as inactive precursors called kininogens, and they are activated by enzymes called kallikreins. And the kinin system is considered a link between coagulation and inflammation. That's because kinins contribute to inflammation, and they can be generated by factor 12, which, as we just saw, is part of the coagulation system. The most important member of the kinin system is bradykinin. It's a vasodilator, it increases vascular permeability, and it can cause pain. And bradykinin is relevant in two clinical scenarios. The first has to do with ACE inhibitor drugs. Bradykinin is degraded by angiotensin converting enzyme, or ACE. So if you administer an ACE inhibitor for hypertension or heart failure, this can raise the bradykinin levels. This can lead to a dangerous side effect of angioedema. This is swelling of the face and tongue, and it's a result of bradykinin causing vasodilation and increased vascular permeability when the levels get too high because of ACE inhibition. The other clinical tie-in to bradykinin has to do with hereditary angioedema. Bradykinin is also degraded by the C1 inhibitor protein. This is part of the complement system, and if you are born with a deficiency of the C1 inhibitor, you can develop high bradykinin levels, which will lead to episodes of swelling. This is called hereditary angioedema, and I talk about it in more detail in the immunology modules. But for our purposes here, I just want to point out the two clinical scenarios where bradykinin is relevant. That has to do with ACE inhibitors and hereditary angioedema. The reason we are talking about kinins like bradykinin in a module on coagulation is because factor 12 can lead to the synthesis of bradykinin. Factor 12 activates clotting, as we saw before, but it also leads to the production of bradykinin. Now, in order for factor 12 to produce bradykinin, it needs help from two cofactors. One is called prekallikrein, the other is called high molecular weight kininogen. Factor 12 can convert prekallikrein into kallikrein, and kallikrein can then convert high molecular weight kininogen into bradykinin. But the bottom line is that factor 12 is capable of generating bradykinin, and thus it provides a link between the coagulation system and the kinin system, which is related to inflammation. There is a very rare condition where children are born with very low or absent levels of prekallikrein. It's called a prekallikrein deficiency. When this happens, factor 12 cannot normally produce bradykinin. In addition, factor 12 cannot normally activate the coagulation system. For this reason, these patients have a markedly prolonged PTT blood test, because remember, factor 12 is the basis of the PTT blood test. Interestingly, these children usually have no bleeding problems. They usually come to medical attention when someone does a routine test of the PTT. The reason they don't have bleeding problems is because, like I told you before, factor 12 doesn't have a lot of physiologic significance. Its greatest significance is as a basis for the PTT blood test. So the kinin system can be very confusing. Its physiological significance is not entirely clear. It's still being studied. I've summarized on the screen some of the most important things for you to remember. It's activated by factor 12, and therefore it's an offshoot of the coagulation system. It serves as a link between coagulation and inflammation. Bradykinin is the most important kinin. It's relevant to ACE inhibitors and hereditary angioedema. And then in the rare prekallikrein deficiency, factor 12 does not work normally. This leads to an elevated PTT in absence of bleeding. So now we've talked about all the ways the coagulation system can activate and form fibrin. What I'm going to do now is talk about coagulation inhibitors. These are naturally occurring substances that are deactivators of the coagulation system, and they keep it from overactivating and forming too much fibrin. First, let's talk about antithrombin 3. Antithrombin 3 is a serpin, which means it is an inhibitor of serine proteases. And as I told you before, many coagulation factors are serine proteases, and a number of these are inhibited by antithrombin 3, including factors 2, 7, 9, 10, 11, and 12. It's produced by the liver, and it's activated by the endothelium. The way that the endothelium activates antithrombin 3 is by making a substance called heparan sulfate. These molecules activate antithrombin, and then it exerts its role on these clotting factors. And this is the basis for drug therapy with the anticoagulant heparin. What heparin does is mimic the effects of heparan sulfate and therefore activate antithrombin 3. And I talk about this in detail in the video on anticoagulant drugs. If you are born with a deficiency in antithrombin 3, then you will have a hypercoagulable state. And that should make sense to you because the job of antithrombin is to dial back the coagulation cascade. So if you're missing it, you will be hypercoagulable and prone to forming clots. And I talk about this in the video on hypercoagulable states. Protein C and protein S are glycoproteins synthesized in the liver, much like many of the clotting factors. Protein C is a zymogen, which means it's inactive. Its active form is called appropriately activated protein C, or APC. And APC's job is to inactivate primarily factors 5A and factor 8A. The way that protein C inactivates those clotting factors is somewhat complicated. Protein C is activated by thrombomodulin. This is a cell membrane protein found on endothelial cells. Thrombomodulin binds to thrombin when it's present, and together they activate protein C. What this means is that when the endothelium is healthy, it will be producing lots of this cell membrane protein, and that will be activating protein C so that blood clots don't form on top of healthy endothelium. The reason protein C and S are usually talked about together is because activated protein C requires protein S as a cofactor. Protein S circulates in an active form. It's not a zymogen, and it can bind to activated protein C to inactivate factors 5A and 8A. So I've shown this schematically at the bottom of the screen. Protein C can be activated by thrombomodulin bound to thrombin. It becomes activated protein C. This picks up protein S as a cofactor and then can inactivate factors 5A and 8A. And the clinical significance of protein C and protein S is that patients are sometimes born with a deficiency of one or both of these enzymes. They will be hypercoagulable. In addition, patients with the factor V Leiden mutation have a mutant form of factor V that cannot be inactivated by protein C. Those patients are also hypercoagulable. We'll talk about this in another module. The final deactivator of the coagulation cascade is called tissue factor pathway inhibitor. Its job is to inactivate 10A. It does this via two mechanisms. It can directly bind 10A and deactivate it. It can also bind tissue factor 7A complex and prevent factor 10 from becoming activated. There isn't a lot of clinical relevance of this pathway inhibitor. The one thing you may want to remember is that plasma levels have been shown to be increased with heparin administration, and it's thought that tissue factor pathway inhibitor may contribute somewhat to the antithrombotic effect of heparin. So now we've talked about how the coagulation cascade can be activated to form fibrin. We've also talked about how it can be deactivated. What I'm going to do now is talk about how clot is broken down once it's formed, and that is the job of plasminogen and plasmin. So plasminogen is synthesized by the liver. It is an inactive enzyme. It is a zymogen. It's converted in the plasma to the active enzyme, which is called plasmin. And the main role of plasmin is to break down fibrin clot so it does not sit in the vascular tree and obstruct blood flow. Now, it turns out it has a broad substrate specificity. It can also degrade clotting factors and fibrinogen, but its main job is to break down fibrin. There are several naturally occurring substances which are plasminogen activators. Tissue plasminogen activator, or TPA, and urokinase are synthesized by endothelial cells and other cells in the body. They activate plasminogen to plasmin and clean up any fibrin that is formed inside of blood vessels. These two plasminogen activators can be used as acute drug therapy for acute MI and stroke. In these instances, they are being used as clot-busting drugs to break up the thrombus that is obstructing blood flow either to the heart or to the brain. There is also a plasminogen activator called streptokinase, which gets its name because it's a streptococcal protein. It also activates plasminogen, and it also can be used in acute MI and stroke. So now let's imagine that a large clot forms in the body, for example, a pulmonary embolism lodged in one of the branches of the pulmonary artery. What will happen is that healthy endothelial cells will release TPA and urokinase, and this will activate plasmin, and plasmin will begin to break down that clot. It turns out that the clot is broken down into two breakdown products which we can measure in the serum and use for diagnosis of certain conditions. One of those breakdown products is called a fibrin degradation product. The other is called a D-dimer. So let's now talk about FDPs and D-dimers to understand where they come from and how they can be used in the diagnosis of clotting disorders. To understand this, let's go back to our map of the coagulation cascade and recall that the final step in the cascade is the conversion of fibrinogen into fibrin. We're going to drill down on this and understand this step in more detail so that we can understand fibrin degradation products and the D-dimer. Fibrinogen is a large glycoprotein that has two domains. The central domain is called the E domain, and then there are two side domains called D domains. If you look at this picture on the screen, this is a representation of what fibrinogen might look like, with an E in the middle and two Ds on the side. When thrombin converts fibrinogen into fibrin, the fibrin molecules begin to link together and form a mesh. Then factor 13 cross-links the fibrin mesh and adds these bonds that I'm circling right here. These are the cross-linked bonds that stabilizes the fibrin mesh and makes it stronger. When plasmin breaks down the fibrin mesh, it breaks it down into two separate pieces, two separate breakdown pieces. One are called the fibrin degradation products. The other breakdown pieces are a special type of degradation product called a D-dimer. So the D-dimer is really a special type of fibrin degradation product, and what's special about it is it contains this bond right here, which is the cross-linked bond formed by factor 13. What this means is the presence of D-dimers in the plasma indicates that cross-linked fibrin clot is being broken down. You can only get D-dimers if you have breakdown of cross-linked fibrin from factor 13. And for this reason, an elevated D-dimer is useful for the diagnosis of DVT or PE. If you have a blood clot like a deep vein thrombosis or a pulmonary embolism that plasmin is trying to break down, it will form small fibrin degradation products which you can measure in the plasma, but it will also form D-dimers which can be measured in the plasma. You can see a rise in the level of fibrin degradation products in the setting of breakdown of clot. However, FDPs are generally not used to diagnose thrombotic disorders like DVTs or pulmonary emboli. Partly this is because FDPs do not have the same sensitivity and specificity as the D-dimer test, but another reason is that you can see a rise in the level of fibrin degradation products in the absence of clot if there is extensive fibrinogen breakdown. Plasmin can directly convert fibrinogen into fibrin degradation products without going through the step of clot formation. If you look at this picture on the screen, fibrinogen has an E domain in the middle and two Ds on the sides. Plasmin can break fibrinogen down into small FDPs without clot formation. For this reason, FDPs only indicate plasmin activity. They don't necessarily indicate clot breakdown. There is a rare condition called primary fibrinolysis where plasmin becomes overactive. In this setting, you will see a rise in the level of fibrin degradation products with a normal D dimer. This is something you should definitely know for step 1 of your boards. These are very rare scenarios, but board examiners like to ask you about this to see if you understand the different origins of the fibrin degradation products and the D dimer. These conditions are sometimes called hyperfibrinolysis. Plasmin is breaking down fibrinogen, but not fibrin, to form FDPs. There is no clot or cross-linked fibrin present, so no D dimers are produced. Plasmin, in addition to breaking down fibrinogen, can break down other clotting factors as well. So in these disorders, plasmin can deplete the other clotting factors, and you can see increased PTT and PT with bleeding, much like in the setting of disseminated intravascular coagulation. A place where this sometimes occurs is in patients who have prostate cancer. There can be release of urokinase from cancer cells from the prostate. This can also be seen in cirrhosis, where there's loss of alpha-2 antiplasmin, which is an inhibitor of plasmin. It's produced by the liver, so when these levels fall, plasmin can become overactive, and that can lead to extensive fibrinolysis. So here are some key points to remember about fibrin degradation products and the D dimer level. When you have breakdown of clot, you will see increased levels of fibrin degradation products and D dimers. When you have hyperfibrinolysis and overactivity of plasmin, you can see increased levels of FDPs, but the D dimer level will be normal. An elevated D dimer level is used sometimes to make the diagnosis of thrombotic disorders. The D dimer level can be elevated in deep vein thrombosis and pulmonary embolism. It is a relatively sensitive test for these disorders, but not very specific. The D dimer level is elevated in many other disorders, and when you do your clinical rotations, you'll learn how to use the D dimer level to try and make a diagnosis of one of these conditions. I'll finish this module with two other quick points about the coagulation cascade. The first has to do with vitamin K. Vitamin K is required for the synthesis of many of the coagulation factors. They are called vitamin K dependent clotting factors. These include factors 2, 7, 9, 10, and protein C and protein S. Patients who are deficient can develop bleeding, and the mechanism of warfarin's effect as an anticoagulant is to antagonize vitamin K. And I talk about this in more detail in some of the other modules. The last topic I want to mention for this video is the erythrocyte sedimentation rate, or the ESR. This is the rate of red blood cell sedimentation formation in a test tube. Basically, you take a sample of a patient's blood, you place it in a test tube, and you measure the rate or the speed at which the red cells settle to the bottom of the tube. Normal is 0 to 22 for men and 0 to 29 for women. And what you need to know about the ESR is that it is increased in inflammatory conditions. So anything in the body that causes inflammation can raise the ESR. The reason this happens is because in the setting of inflammation, protein levels in the plasma increase, and those proteins are sticky, and they cause the red cells to clump together, and therefore they settle faster to the bottom of the tube. That means that the rate of sedimentation formation will go up. The ESR will go up when any inflammatory condition is present in the body. So what you'll read in textbooks is that the ESR is increased by so-called acute phase reactants in the plasma. These are serum proteins whose levels rise in the setting of inflammation or tissue injury. This is usually driven by increased production of cytokines. Most of these proteins come from the liver, and the liver makes more of them in the setting of inflammation or tissue injury. There are lots and lots of so-called acute phase reactants, but some of the most important ones I've listed on the screen. One of them is fibrinogen, which you now understand is part of the coagulation cascade. The liver makes more fibrinogen in the setting of inflammation or tissue injury, and this will lead to an increased ESR. Other important acute phase reactants, which we'll talk about in other modules, include ferritin and C-reactive protein, which can bind bacteria and can activate complement. And that concludes our module on coagulation.